Hello, my name is Laurel Riek. I'm a professor at UC San Diego and have appointments in the Department of Computer Science and Engineering, as well as the School of Medicine. I'm a roboticist and computer scientist, and I direct the Healthcare Robotics Lab. And we build autonomous robots that can sense, understand, and learn from real people in the real world. I'm really interested in both fundamental and applied problems to enable real-world autonomy for robots and intelligent systems, including robot perception, long-term learning, and multi-human, multi-robot teaming. And I work across a range of sectors, though I focus primarily on safety-critical environments, including emergency medicine, critical care, and home health. Critical environments are complex, non-deterministic spaces where people have a high workload, are under time-sensitive constraints, and must make decisions under uncertainty. Examples include emergency medicine, disaster response, and assembly manufacturing. Here, a key problem is operational failure, which is when a person doesn't have the supplies, equipment, or information that they need to complete tasks. These failures can be fiscally devastating, costing tens of billions of dollars annually. Though far more troubling, in contexts like healthcare, it can lead to grave patient harm and death. In fact, in medicine, over 400,000 people die in US hospitals alone due to preventable medical errors, and over 5 million are seriously injured or disabled. This is actually the third leading cause of death in the United States. And what's remarkable is that these deaths are entirely preventable. In fact, with better healthcare systems design, we could make this number disappear entirely. So the reason these adverse events occur is twofold. First, clinicians, patients, and family members are often not on the same page, leading to information sharing breakdowns. Also, clinicians may miss important clues and can walk down incorrect diagnostic paths. Second, the majority of technology out there to support clinicians is not built for inculcating safety, and in some cases, it is making patients less safe. So as an engineer, when I walk around hospitals, I really feel a moral imperative to help. So one of the first lines of defenses in patient safety is education, and one of the ways that this is conveyed are through patient simulator systems. So hundreds of thousands of clinicians train on these systems every year, and they enable clinical students to practice their procedural and communication skills on this very lifelike humanoid robot before they treat real patients. So these robotic patient simulator systems are very amazing. They can breathe, they can bleed, they can expel fluids, they can respond to medication. They have over 5,000 physiology variables that a person can tweak, which is super cool. But they look like this. They are completely inexpressive. They're not connected to the environment or aware of it, and the technology does not adequately support either the clinical students or the educators. Students will often learn the wrong skills and need to be retrained, and educators can't run the simulations that they need to. This technology lacks one of the most important sources of diagnostic information available to clinicians, which is an expressive face. We convey so much information in our face. If we're having a stroke, if we are reacting poorly to medication, or if we're in pain. And clinicians need to start learning how to read patient faces on day one. To show you how bad this problem is, here's an image from one of our collaborators. This person sits in the room and acts as a human cue card, voicing facial expressions for the robot. His eyelids are half closed. His face looks pained. She's looking around the room, disoriented. This adds a lot of distraction and delay to the sim, and the students don't learn what they need to learn. So for the past 8 years, my students and I have been working on making robotic patient simulation technology more realistic by giving simulators richly expressive faces and whose synthesis is based on entirely actual patients. Furthermore, this robot has some autonomy and access to external sensor data to be able to perform more tasks independently. Today, I will discuss a few of our projects in this space. So the first clinically relevant facial expression we synthesized was pain. Clinicians need to frequently assess patient pain, but they are very likely to underestimate patient pain intensity, which can lead to poor outcomes. And furthermore, patients who are unable to use verbal communication are at particular risk of having important diagnostic clues missed. Training can help improve clinical facial expression reading, has been shown in the literature, so might robotic patient simulators be able to help? So we've built both robots and virtual characters able to express patient pain. We've developed several methods for conducting the synthesis, though I'll just briefly describe one of them. So what we did in this study is we took data from a naturalistic corpora of patients experiencing acute pain from the Binghamton Pittsburgh 4D Spontaneous Expression Database, or BP4D. We then used a CLM-based facial feature tracker, extracted key points, and performed automatic realistic synthesis on both a 24 degree of freedom robot as well as a virtual avatar. Our system supports both direct control, which is what we did in this study, as well as masked synthesis and shared control for operators. In this study, we explored two key concepts. The first was about embodiment. We were curious to know if people were more accurate in detecting pain expressed on a robot, a physical robot, compared to a virtual avatar. So the literature has conflicting results on this. Most of the studies are with zoomorphic or non-anthropomorphic robots, and most of them only use the Ekman-6, which has been shown to not be valid in terms of true depth of facial expression. And the second question we asked was clinician versus non-clinician. So are laypersons more accurate at classifying facial expressions and judging their intensity compared to clinicians? The literature suggests probably not. Clinicians are routinely worse than laypeople. So the first thing we did was we created the stimuli that we were planning to use in our experiment, and for this we took source videos from the BP4D database where there's naturally evoked pain, anger, and disgust. We ran these videos through a CLM shape-based tracker yielding 66 vertices on the face, and our targets were both a physical robot, which is a 24 degree of freedom robot that resembles Philip K. Dick, as well as an avatar, which was from the Steam source SDK, and this was intended to resemble the physical robot, so it looked very similar. Here are two simile samples. So first you can see the virtual avatar, and here's the physical robot. To design our study, we had 18 stimuli videos presented in random order with a semi-forced choice evaluation. So expressions included pain, anger, disgust, none of the above and then we had a 6-point discrete visual analog scale to measure intensity. And we recruited 102 participants from medical schools and nursing schools all across the United States. This included 51 clinicians and 51 non-clinicians. The clinicians were a mix of registered nurses, physicians, EMTs, clinical researchers, pharmacists, and therapists. Both groups had a fairly good range of ages and were roughly 50-50 women and men. In terms of our results, what we found is that all participants, clinicians or laypersons, were more accurate detecting pain from the virtual avatar compared to the robot, regardless of the expression type or their educational background. We also found that clinicians are significantly worse than non-clinicians at overall pain detection accuracy. With regards to intensity perception, we did not find any significant differences in perceived pain intensity between clinicians or non-clinicians. To summarize our results, what we found is that people are less accurate in detecting pain expressed on a robot compared to a virtual avatar. And these findings are consistent with some recent findings from the HRI literature as well. In our study, it might have been due to subtle differences in the embodiments. So PKD did not have a lot of motion around its nose or cheeks. Of course, neither did the avatar, because we did try to match those. It's possible that there was fidelity issues in terms of the expressions, so a few of these areas around the nose are very important for conveying pain. Second, we found that lay people are more accurate than clinicians in detecting pain, and this supports findings that we've seen in the literature as well. We didn't find any differences in intensity perception, and again, this could be due to the differences between acute and chronic pain perception. So the BP4D database tends to have acute pain because people are submersing their hands in ice water, whereas for chronic pain is expressed quite differently in the face. So that could have been the reason for that result. So the next clinically relevant facial expression that we explored was Bell's palsy. And here we were really interested in particularly exploring conditions related to facial paralysis. So facial paralysis is the inability to move one's facial muscles on the affected side of the face, leading to asymmetric facial expressions. This is a frequent condition seen in people with Parkinson's disease, stroke, and Bell's palsy, which are important clinical conditions affecting 22 million people worldwide every year. Both lay people and clinicians have difficulty understanding facial expressions in people with facial paralysis. They often misinterpret them, which can result in both poor social interactions and poor care delivery. In our recent IEEE Face and Gesture paper, we presented a new method to build accurate computational models of people with Bell's palsy that are constructible in real time. Our method works as follows. First, we acquired videos of people with Bell's palsy expressing a range of facial expressions. Then, we extracted facial features using a CLM-based approach. Following that, using the 2D coordinates of the 34 facial features of the unaffected side of the face, we calculate the 2D coordinates for the other part. We then divide the actual coordinates by the calculated coordinates to yield a scaling parameter, which represents the facial characteristics of each person with Bell's palsy. So to evaluate our masked synthesis approach and get feedback for further refinement, we ran a quantitative expert-based perceptual experiment. Here, we created 2 video datasets representing those required in a Bell's palsy diagnosis. The first is a diagnostic dataset, where a performer without Bell's palsy was recorded while performing 5 facial expressions required for a paralysis assessment: closing the eyes, raising the eyebrows, furrowing the brow, smiling, and raising the cheeks. We also collected an interview set, where a performer, again without Bell's palsy, answered a list of questions that a clinician asks when diagnosing Bell's palsy patients. And the goal here was to record natural expressions that happen during interaction between a Bell's palsy patient and a clinician. From these videos, we used the CLM face tracker to track 68 facial points frame by frame and extracted facial features of the performer's face. We then applied the scaling parameters corresponding to each of the pre-built Bell's palsy masks to the extracted feature points of each video. Then, based upon these masked feature points, we transferred the generated asymmetric facial expressions to the face of a virtual patient simulator. At the end of this process, we had a total of 18 stimuli videos to use in our study. Following this, we ran an expert-based perceptual case study with 4 clinicians familiar with assessing facial paralysis in Bell's palsy patients. Here, participants watched the stimuli videos in random order. They were then asked to rate how similar the avatar was to real Bell's palsy patients, both for the entire face and per facial part. So what we found is that overall, clinicians thought that closing the eyes and smiling were the most similar expressions to real Bell palsy patients. These similarity scores also show that overall, the second mask created more realistic diagnostic expressions. We also found that for the entire face, and all the facial parts except for the eye, the third mask created natural expressions that are more similar to real Bell's palsy patients. These results also suggest that overall, clinicians thought that the eyes were the most similar part of the face to real patients, and the cheeks were the least similar part of the face to real Bell's palsy patients. Our work in this paper is a first step toward building complete expressive robotic patient simulator systems capable of recognizing and synthesizing asymmetrical facial expressions in an educational setting. In our work to date, we've developed an automatic method for real-time facial expression synthesis on physical robots and virtual avatars, and we've built accurate computational models of people with Bell's palsy that are constructible in real time. We experimentally validated our approach within a clinical education context and found that clinicians perceive our patient simulators to be realistic and comparable to humans who have Bell's palsy. In the future, we ultimately plan to run a similar experiment with clinical learners using an expressive robotic patient. This may help clinicians avoid forming biased impressions of people with facial paralysis and improve their cultural competency. Also, it may improve their skills in understanding the emotions of people with asymmetrical facial expressions, which can lead to better health outcomes and reduce health disparities. We hope this work will help improve the state of the art in clinical education, as well as help us to explore new methods for synthesizing facial expressions in the greater effective computing and patient simulation communities. Briefly, I will discuss our recent work, which explores modeling stroke. Stroke causes paralysis and sensory impairment, and 15 million people each year are affected by stroke. It's the second leading cause of death worldwide and the 4th most common misdiagnosis. Effective clinical training in the delivery of neurological exams and interpretation of their findings can help improve clinicians' confidence in their exams, increase the accuracy of stroke diagnosis, and reduce the incidence of preventable patient harm. Unfortunately, right now, there are no patient simulators capable of mimicking the facial cues and pathologies that are important for the rapid diagnosis of neurological emergencies. We've been working with neurologists to create an intelligent, interactive training tool with a realistic, expressive face for clinicians to practice their stroke diagnosis skills. We're exploring this within the context of patient interaction and improving skills in decoding visual signals of stroke. The tool is capable of representing a diverse group of patients with different ages, genders, and ethnicities. Our work is ongoing in this area, but it's something we're very excited about. We hope that this work collectively can help improve clinical education and ultimately reduce missed stroke diagnoses, which we plan to explore in the future. With that, I will conclude. I'd very much like to thank my students and sponsors, and I look forward to taking any questions you have.